But there's been a CheckMate trial that was combination that was successful. That was ipi-nivo, right?
Right. That's the 9DW.
Yeah. Can you elaborate on that one, Adam?
So this is the kind of most hot off the press data. Those CheckMate-9DW was presented at both ASCO and ESMO this year, which is looking at frontline ipilimumab plus nivolumab, which is, again, combination of CTLA-4 and PD-1 inhibition, versus the difference here was it was dealer's choice TKI for the comparator arm. So in the evolving years since IMbrave 150 and Himalaya, lenvatinib sort of became the preferred TKI over sorafenib. So one difference of CheckMate-9DW was that actually the majority of patients in the comparator arm did receive lenvatinib, not sorafenib, which is probably why we saw that comparator arm overall survival actually be quite long. But the top line data itself was very impressive with a median overall survival of now approaching almost 2 years, which, again, we're talking about advanced HCC patients that we used to tell really had less than 6 months to live. The trade-off here, as we're thinking about all of these regimens now that we have access to, is we do know that ipilimumab does have a higher rate of immune-related adverse events in these combination strategies with Nivo, and a bit higher than the other dual immune checkpoint blockade strategy with STRIDE that we already have access to. So, this is, still awaiting approval in the frontline setting. We're still waiting on the final publication of the data. It's certainly encouraging and exciting, but how it's going to fit into our treatment landscape, I think, remains to be unseen.
Yeah, I think the dosing part is very interesting. It's when our GI oncologists look at a GI trial, a lot of GI trial, when they're using ipi-nivo for GI cancer, they actually use a more tolerable regimen, which is ipilimumab at 1 milligram per kg plus nivolumab 3 milligram per kg. That's actually an easy way to tolerate, relatively easy way to tolerate it. But then there's a CheckMate-040 before the 9DW study that showed that the easy way, like ipi-1, Nivo 3, actually did not work that well. And the only winner from that trial was the ipi-3, Nivo 1, and that's the hard, difficult, toxic regimen. So that was tested in 9DW, very amazing result. But even if you look at the survival curves, over survival curves from these 3 trials, it's very interesting. So on the IMbrave 150, the survival curve for Tezo-Bev and the sorafenib arm started separating from each other very early in the treatment course. Almost like once they start, they separate from each other. On the Himalaya trial, the 2 curves sit on top of each other for a little while and then start separating. Like the median overall survival in the Devitremi arm was 16 months or so, but it's really the tail that is impressive, that a lot of people, not a lot, there's 15, 20%
20% of 5 years.
Exactly, 5-year survivors. But when you look at the CheckMate-9DW trial, in the beginning, both the progression-free survival and the overall survival curves, there's a crossover. So in the beginning, the ipi-nivo arm actually did worse. More people die and more people progress. And then there's this crossover. And then eventually, people who survive become the winner in the long term.
That's very interesting. So to sum up, we have IMbrave, which is atezo-bev. We have Himalaya, which is durvalumab, and then we have CheckMate-9DW, which is ipi-nivo, right? And all of those showed improvement in overall survival. The tail changes, do you think that could be related to the etiology of the cirrhosis? Now, as I understand, the IMbrave, I think, was more Hep B positive patients. I might be wrong on that one. Probably shouldn't even speak to that. But do you...
there are less non-viral compared to Himalaya. Himalaya has about 40% non-viral. IMbrave has about 30% non-viral.
Okay.
That's actually a great question. We debate this all of the time, or at least discuss it. What's the data on immunotherapy with viral etiologies versus non-viral etiologies?
That's a great question.
We are actually, Lingling and I were having this conversation this morning because we're really cool. I think initially there was, I think we probably all have maybe different perspectives on this, but I think initially there was definitely a thought in the field that viral etiology does better with immunotherapy-based regimens, and maybe perhaps a TKI is more appropriate for non-viral. And then I think now study upon study and meta-analysis have shown that's actually probably not the case, that really there's not a patient where their etiology should factor into whether they're getting immunotherapy first line or not. Everyone should be getting immunotherapy first line as long as they're eligible for it. That's how I interpret the most recent data. I don't know if anyone feels differently.
Yeah, I totally agree in terms of what we know about HCC and etiology now. We're not really using it clinically to, choose regimens. And then I think we all do have different schools of thoughts on this. My personal bias is that if you look at the preclinical data that initially looked at this sort of non-responsive, potentially viral-driven HCC, there was this exhausted T-cell population. And, at risk of sounding like a hospital administrator, I think of this more as a opportunity to overcome that resistance because we know that these combination strategies are important. And because these regimens are tolerated, we can bring in third agents. We can have triplet regimens that perhaps would overcome that T-cell exhaustion and make that cold tumor hot, if you will, and allow patients to respond to immunotherapy regardless of etiology. And I think as we learn more about that biology, perhaps viral versus non-viral etiology will become more important.
Okay. I might hit you back up on that triplet therapy in a minute. Obviously, all of these trials showed improvements in overall survival. Are there any other things that you look at as an oncologist? Do you look at any other factors or any other outcomes other than overall survival?
Response rate.
Response rate?
I do care about response rate. When people are very symptomatic, high tumor burden, I tend to pick the one that has the highest response rate.
I think in terms of efficacy outcomes, overall survival's to me the most important. Response rate in the right patient matters. In some patients, it doesn't really matter, right? They have asymptomatic disease and a few lung mets. I mean, I don't know that really matters what the response rate is per se. I think the other thing is, we've been kind of alluding to these tails of the curve. I think these long-term landmark time points matter. So in Himalaya, you might see a difference of median overall survival of just a few months between the experimental and control arm. But in terms of those curves separating, you having a chance to be alive at 4 or 5 years down the road, I think that's a meaningful endpoint too, is what the 3, 4, 5 year overall survival is, because, ultimately that's what patients are looking for. I think an extra few months is obviously not nothing, but years is what's really going to make a difference in outcomes.